I literally grew up with shoulder surgery, and my feeling is that reverse shoulder arthroplasty is perhaps the most exciting innovation or development in the field of shoulder surgery in the last 25-30 years. So let me I'm going to speak about, I've been asked to speak by Dinshaw, the role of reverse shoulder in massive irreparable rotator cuff tear. So this is, as the previous speakers have already told you, that there are various options, and I'm going to speak on the last two over here. The flow of my talk is, a few lines about when to do it. I see a lot of senior orthopedic surgeons who do arthroplasty as well of the knee, and therefore some technical tips, my interpretation and experience, the results and complications, the world literature as of today, and the limitations of reverse shoulder arthroplasty. So I presume that when Dinshaw told me to speak on reverse in irreparable cuff tear, I presume it is without arthritis. Therefore, Hamada 1, 2, and 3. And therefore, it means that whenever you have a massive cuff tear with chronic loss of elevation, which is for more than 6 months and has failed all other methods of treatment such as physiotherapy and the conservative line of treatment, then it becomes an indication to be considered for reverse shoulder arthroplasty, and the US FDA official approval is for the age above 70. But of course it's being done in much younger age group nowadays, even in United States. So which patient is ideal for reverse shoulder? This is a very important slide. Please remember this, that if you have a massive cuff tear and the elevation should be less than 90 degrees, because you do have massive cuff tears, as the previous speakers throughout the morning have said, where they have very good function. So I am reluctant to do a reverse shoulder in patients with massive cuff tear who have good functional movement. Why? Because these patients may end up a bit unhappy, and you may end up by doing a reverse with a lesser movement than pre-op. So mind you, pseudoparalysis, massive cuff tear, relatively elderly age group with less than 90 degrees of elevation is the indication. Now, massive cuff tear, you can have, this is just to touch up because Deepak Bhatia has ditched us, and I'm told that's his habit. So I'm going to talk a few lines about when to do a long head of biceps sternotomy and partial cuff repair. So I divide massive cuff tears into two groups, those with good function and those with poor function. As I said earlier, if you have an elderly patient with poor function, reverse is my first choice. But if you have good function and the patient is elderly or sometimes even young, then you can consider a partial repair with a long head of biceps sternotomy if the long head of biceps is intact. But if you have a young patient with good function or poor function, I am reluctant to do a reverse, and that's where this set of treatment fit in. You can do SCR, as Dinshaw very nicely showed, tissue patches like Mihata, or a balloon spacer. This is from Israel. And then muscle transfers, of course, can be considered in young patients with good function or with poor function. So that is where long head of biceps sternotomy and partial repair fits in. And in partial repair, the concept is very simple. We all know Stephen Burkhart's work, that if you have an intact force couple, or if you can reconstitute the force couple in terms of infra or teres minor and subscap, then even in the absence of a functional supraspinatus, you can have reasonable pain relief and forward elevation. Another important point in patient selection, when you do a reverse, often these patients have had one or two or multiple failed cuff surgeries. And remember that when you do a reverse for a massive cuff tear in patients who have had previous cuff surgeries, the result might be slightly inferior than a virgin case. So this is a typical, very classic, if you steal a look here, 80-year-old, very, very typical case of a massive cuff tear, not so much of glenohumeral arthritis, with almost completely gone supra-infra. Now, a few technical issues about reverse shoulder arthroplasty, where we came from, where we are today, and the future in terms of the design and the evolution of reverse shoulder component. So this was the original reverse component which failed. And this failed because this is from the Lippmann-Kessel time, because it had a neck and there was lateralization of the center of rotation, too much stress on the glenoid bone implant interface. So it had to fail. Now all the modern designs of reverse shoulder arthroplasty are Paul Gremot based. Paul Gremot, who popularized, he did not really invent reverse, but this particular design was his baby. And you'll be surprised to know that this procedure is being done for last 30 odd years. So it's not a new procedure. And the basic difference in the design, if you notice, it's called a large glenosphere. There is no neck. Therefore, there is medialization and distalization of the center of rotation, which gives a mechanical advantage to the deltoid, and the deltoid can function as a forward elevator. And this is a semi-constrained design because that adds static stability to the whole construct. And it is a valgus cut to enhance that static stability. Again, how deltoid can do the job of forward elevation. We all know Kapanji's work, very old work, 1970s, that the deltoid is divided into 7 functional components. And this is the normal glenohumeral joint. And see the amount of deltoid that is recruited for forward elevation in a normal person is component 2 and component 3. But if you simply medialize the center of rotation, then twice the amount of deltoid is recruited for forward elevation. So that's a simple biomechanical principle on which the reverse shoulder arthroplasty works. Now, very important technical tips for those who want to do or are doing reverse shoulder arthroplasty. A few questions I will answer very quickly. When you make the humerus cut, what angle and why? When you put your component in retroversion, should it be 0, 10, 20 or 30 and why? Tips about metaglean fixation, selection of glenosphere and when to do a lat torsi transfer along with reverse shoulder. Approach, for all virgin cases, I do a superior Mackenzie approach, and for all revision cases, because they usually have a deltopectoral incision already, I do a deltopectoral approach. Now, when you make the humeral cut, should you cut 130, 150, 170 and why? I prefer 145 degrees, and let me give you the reason why I do that. The more valgus, the more stability, inherent stability in the implant. The more valgus, which is 170. But then this is going to cause a lot of impingement of the glenoid neck. So this is not available in the market at all. This is just to give you an idea. The original Gremot design was 150. That also causes a significant amount of scapular neck impingement, and I'll show you some of my cases done 8 or 10 years ago. So somewhere in between 130 and 150, which is around 140 or 45, is my choice. Then how much of retroversion should you select? Some say 0, some say 10, some say 20. I select 10 and I will tell you why. Now, reverse shoulder arthroplasty and exploiting the deltoid is a very good idea, but it is a very poor rotator. The reverse shoulder does not allow you or provide you with external rotation in particular. And remember, all these are patients with infraspinatus gone. That's why you are doing a reverse shoulder arthroplasty. So it does not provide an external rotation arm. So you are relying on teres minor. Now, if you put the head in too much of retroversion, then you get a teres minor increase in length, a reduction in moment arm, but you might end up causing anterior impingement of the humeral component anteriorly on the glenoid. So in trying to balance optimum rotation and exploiting the subscap and teres minor moment arm, the ideal is about 10 degrees of retroversion. So that's what I use, a 10-degree retroversion, somewhere between 0 and 20, to avoid impingement as well as to exploit the available rotators. Next technical tip, the key of the whole surgical procedure is how well you fix the metaglean, which is the base plate. This is the nerve, we all know that. Look at the bone density. This is pillar 1, pillar 2. These are the most dense part of the scapula. So therefore, the two screws which are very critical is base of the coracoid and the inferior pillar. And if you can get along the spine of scapula, wonderful. I will show you a very simple trick. You take a torch, take a scapula piece bone, and if you illuminate it with a torch, you'll see where the bone is, the dense bone is. So you must understand that your this screw 1 and screw 3 are extremely important. If you do not know how to get those screws, your surgery will fail on day 1. I normally prefer 3 screws at least out of the 4. And in order to catch those dense bone, I prefer to use a model of reverse arthroplasty which allows me to use variable angle screws, because there are some companies which have only fixed angle screws. So that's why my desire to have that particular type of implant which allows me to catch that upper pillar and the lower pillar. Last, soft tissue tensioning. If you do not tension the shoulder well, you will have an unstable reverse which can be a disaster. 3 important tests. Most reliable one is of course the shock. Check the tension on the conjoint tendon, and you can ask your assistant to put a fist in the axilla and adduct and see whether it is unstable or subluxating. Now the main problem in the last 20 years with the original Gremot design was, number 1, scapular notching. Number 2, the Gremot design does not restore rotations, and you get a loss of shoulder contour, which is a cosmetic problem. There are 3 issues. So here is what is scapular notching, like I showed you. The French group has graded scapular notching into 4 grades, as you can see here. Grade 4 is when it starts impinging on the screw itself. So this is my case done, I think about 10 years ago. She's a lady now in her 80s, and you can see that the screw is getting notched. But fortunately, it has not led to any loosening of the glenoid component, and she continues to do well. So how do you prevent or minimize notching? One is, I have moved from 150 to 140 degrees cut. That is number 1. I tend to use an eccentric glenosphere. I'll show you. Put it with a slight inferior tilt. And now the latest is, instead of medializing, you lateralize the glenoid component. So here is an example of an eccentric glenosphere. You place the glenosphere slightly inferiorly, like you see here, and that reduces the incidence of notching. So here is an animation which I have made just to help you understand how the 150 degree cut leads to scapular neck impingement. The other trick is to place the glenosphere with an inferior tilt. That also reduces to some extent scapular notching. And then you can use glenoid glenosphere with a larger offset. So what are the limitations of the reverse shoulder arthroplasty? It does not provide external rotation in particular. And therefore, beware, pre-op you must assess the status of teres minor. If the teres minor is torn or non-functional, you will not have a happy patient of reverse shoulder arthroplasty. Patient will tell you that, doc, when I raise the arm up, I lose control. It drops in. So I have difficulty brushing, I have difficulty combing my hair, and I'm not happy after this joint replacement surgery of yours. And this is the reason I'm quite intrigued that nature has provided only 2 external rotators to us, namely the teres minor and the infraspinatus, as against we have 4 internal rotators. So this is what the patient will complain. So beware, pre-op you must check if Hornblower's sign is positive. And like the previous speaker has mentioned about tendon transfer, this is what I do quite routinely. I will give you the incidence in my series. In about 12% of patients, I have done a lat dorsi teres major transfer to provide an external rotation force to the reverse shoulder arthroplasty. And they do quite well, reverse shoulder combined with transfer. Now lateralization is the new mantra. We are moving away from the Gremot design in terms of the center of rotation. You will be surprised that today as I talk, there are 36 models of reverse shoulder arthroplasty in the market, 36. And depending upon which company model you use, you can get a lateralization effectively of up to 32 to 33 millimeters. So it's massive, and nobody is very clear yet what is the optimum amount of lateralization that you should try and achieve, for 2 reasons: to reduce notching and to get rotations. So here is one of the cases. This is a bone graft. This technique is developed by Pascal Beaulieu and Gilles Walsh. A lot of erosion of the glenoid. You can see almost there is no glenoid there. And how by using the autograft from the head, you can put the bone graft and then an implant over the bone graft, thereby lateralizing. So your take-home message: select a model, select an implant which allows you to cut the humerus at somewhere around 135 or 140 degrees, and if you can lateralize the glenoid by 5 millimeters, that is ideal. In summary, reverse shoulder arthroplasty is an excellent pain-relieving implant. It does improve shoulder function. Average constant score is about 70, but it has a high complication rate. Instability is the most common one. Scapular notching stands second, and of course a fracture intraoperative. So if you look at the literature, the complication rate, I want you to notice that these are all people with massive experience: 484, 457, 240 cases, and look at their complication rate: 25, 12, 71, 50. So the average complication rate is quite high. I'm not trying to scare you, but I'm just trying to make you aware that it's not a surgery you take up casually. You have to be well trained. You should have the concept and the fundamentals clear. But reverse shoulder arthroplasty is here to stay. It's a big boom in the world today, and it does provide a promising, reliable option with more than 15 years of follow-up. So this is an example of a cuff deficient shoulder in a 72-year-old lady that is about 4 months post-op, forward elevation, external rotation, and internal rotation. So in summary, if you have a massive cuff tear with functional shoulder, I would be reluctant to do a reverse. These are the options. Whereas if you have a non-functional shoulder with a massive cuff, if there is a loss of only elevation, reverse shoulder is enough. If there is a loss of elevation with external rotation, you need to add a muscle transfer. Do not take up reverse shoulder casually. These are examples of complications. 70-year-old male, a surgeon, done somewhere, dislocated. This is severe pain, infected, and this is disassociation of the whole implant. Thank you very much. Thank you, BOS, once again.